Everyone. It's my great pleasure to open today's event. I'm Janet Doldrin. I'm a professor in the law school and director of the Gitenstein Institute for Health Law and Policy and the Hofstra Bioethics Center. Today's event is one of many celebrations of Hofstra's law school, its work, its history. This webinar will show you something about the work of the Gitenstein Institute and the Bioethics Center. That work aims to improve health and to expand access to healthcare. And I'll just now note two of our projects. We have lots more, but both of these are relevant to today's presentations. The Medical Legal Partnership with Northwell, about which you'll hear more during the presentations, and our bioethics programs. And in the latter regard, it's I have some really exciting news. We are launching, almost even as I speak, an MA in bioethics at the law school. More information about it is available on the Gitenstein website, and I think Joel Roslin will put the link into a chat to everyone. This webinar is part of a series of events supported by the law firm Garfunkel Wild. We are always grateful to the firm and to its partners for their generous support over the years. We have a really wonderful panel of speakers today, and we're proud to say each has worked with the Institute and or with the center. They each brings important insights about law, medical ethics, public health in general, and more specifically during the COVID-19 pandemic. Each of our panelists has worked actively on the ground with patients and clients during the pandemic. The COVID pandemic has framed the limitations of the US healthcare system and has shown the consequences of eviscerating the nation's public health system. The US has sustained a stunning number of COVID diagnoses and deaths, and it's fared really badly compared to other nations. The statistics are overwhelming. The population of the United States comprises about 4% of the world's population. It accounts for about 20% of deaths from COVID. This reflects the nation's socioeconomic disparities, and it reflects the politicization of public health during the pandemic. Yet, alongside this truly dismal portrait, sits a contrasting picture of particular healthcare institutions and healthcare professionals. Many have responded with true heroism in the face of COVID. And they've done that even though the obstacles have been unendingly daunting. Hospitals and clinicians have been compelled to plan for rationing and triage on a really unprecedented scale. In addition, the limitations on access to healthcare in the United States for some groups of people, far more than for others, have been consequential. These limitations constitute an implicit form of rationing. They affect people with COVID, and they affect other people with other illnesses. The pandemic has revealed the consequences of the nation's unequal distribution of healthcare resources. Distribution of medical and public health resources during the pandemic, testing, treatments, and now vaccine doses has simply not been equitable. Poor people and people in minority populations have fallen ill from COVID more often, have died from it more often, and have received fewer doses of the available vaccines than others. The causes are complex but the facts are clear. Compared to nations that offer healthcare to virtually everyone, the United States has much to lament. We must fix our nation's healthcare system, and we must revive its public healthcare systems. Each of our speakers is working actively to reach those goals. Joel Roslin will now introduce today's speakers. Joel is the Assistant Director of the Gitenstein Institute and the coordinator of the Bioethics Center. Joel?
Thank you, Janet, and welcome everyone to today's very exciting program. We're very pleased to be joined by such remarkable people. I'm sitting in my bedroom of my apartment in Manhattan, and I say that only because I wish we could all be in the same room, because to be in a room with the three remarkable professionals, the three remarkable women that we're going to be hearing from today, is a delight and an honor. And I just hope that come next fall, we will all be able to gather together in person and experience the brilliance, the insight, and the energy that we will all now get a sense of as we meet on Zoom. It is a distinct honor for me to introduce the speakers. I will not go into any detail. It's all available. I will just say our first speaker, Dr. Omolara Uwemedimo, is a physician and assistant professor at Hofstra Northwell School of Medicine and an advocate for patients and for people. Curlan Flowers is an attorney. She's the legal director and senior housing attorney here at the Gitenstein Institute. She's also the director of our medical legal partnership, which is a joint venture of the Gitenstein Institute and Northwell Health. Finally, Professor Renee McLeod-Sorjan is a nurse, is a professor at the School of Nursing, is the co-director of the Hofstra Bioethics Center, as well as a co-director of our new master's degree program in bioethics, and as well as the director of the Ethics Consult Service for all of Northwell Health. So today we expect to hear insight and analysis. Each of our speakers will have about 10 minutes to give you an overview of specific topic that we're looking to address today. And then we're going to save some time for questions. I ask everyone to please stay muted. Please use the chat function to list your questions. We'll be monitoring that, but we won't be taking questions until each of the speakers has had a chance to give their opening remarks. I did post into the chat the URL for our new master's degree in bioethics. With that, I'm going to hand things over to Dr. Uwemedimo. Please take it away.
Thank you so much, Joel. I'm a physician. I am the director and the chief executive officer of Strong Children Wellness. But I think as I come into this space of talking to you all, it allows me to move back and transport myself back to my early career in Malawi and working in sub-Saharan Africa. In the midst of the pandemic, in the first few weeks in March, I was pulled back to the inpatient ward in Lilongwe, Malawi. I was pulled back to another inpatient ward in Lesotho, a small country right on top of South Africa. And I remember having to ration. The word ration has a personal space in my heart because I remember having to ration oxygen and decide what child needed it the most. I never thought that 14 years later, that I would have to do that in the United States of America, that I would have to see that happen. And it now has pushed to the forefront what I think is really important. A lot of the things that have been unsaid, a lot of the things that many of us, particularly those of us who are providers in that come from marginalized backgrounds and communities, myself, African American, but also first generation American and daughter of Nigerian immigrants. And so I want to introduce a case because that's what physicians do a lot of times to teach. And I want to introduce you to a Black woman in her late 30s, an essential worker who's self-employed with a chronic illness and actually a history of a near fatal allergic reaction to injectable medicines that she uses for her chronic illness. When I think about this terminology of social determinants of health, I will be transparent that it hits a nerve. I don't like the term, and I'm going to explain why. And let me bring you to this Black woman and bring you to the fact that she needs to be vaccinated for COVID. The problem is that often the assumption for women who look like her, the many women who are marginalized, is that the lack of vaccination is due to a will or a behavior or a volition problem, that she is hesitant. We've heard that terminology of vaccine hesitancy throughout this new wave of trying to, the new inequity that we're seeing. However, the other assumptions that don't exist oftentimes that we don't think about is that the three tiers of determinants that actually underlie and truly often, I believe, should replace the thought of volition as the sole issue for marginalized populations and the inequities that we see. So let me take you through her process and explain some of these things. The first thing I would say is that usually for this woman, she would need to know that she should get the vaccine. She would need to know that it is safe, and she would need to have that as a priority for her. What that shows us is that there has to be information access. Does she have a TV? Does she have internet? Does she have access to trustworthy sources of messaging that look like her, that come from people from her community? Is she literate? Are those things available? But the second is this hierarchy of needs, Maslow's hierarchy. If we come in contact with people who are not having access to food, clothing, housing, other basic needs, if they're worried about whether or not they'll be able to stay in the country due to their immigration status, the vaccination then starts to move lower and lower in terms of their priority. And a lot of these issues are the fact that these inequities in basic needs, these inequities in information access, are actually what I like to call political determinants. The need for policies that actually create the space for equitable and just fairness in health and ensure access to information and securing these basic needs. The second layer, if she's able to get that information access and have access to, and have actually not access, but the actual manifestation of policies that ensure these basic needs, she must be able to get to care. She must be able to have systems that allow for that care to be accessible. Transport systems, does she have a car? Does she have access to a bus? Health systems, does she live in a health desert like the majority of marginalized populations? And then does she have access to technology that she can easily connect with her provider? She can easily find and search for where she needs to go. These are the inequities from structural determinants. The lack of equitable distribution of health services in not only in spaces, but in spaces that are close to home, that don't rely on that person having to go outside of their means to be able to have a cost, an opportunity cost that is incurred every time they try to seek healthcare. The third thing that I want to mention is that even if she gets to care, even if she's gotten the information and understands that it's safe, she must be treated with respect, valued, listened to. And so often, as many Black women as I know myself, even with the privilege I carry, she must be believed. At the site of vaccination, does she see people who look like her? Does she get asked questions instead of told? Does she get counseled? Does she feel comforted? These are the interpersonal determinants. And we do a disservice when we call all of these things social determinants because they don't give us a way to address them. They don't at least highlight where do we need to look to allow for these things, not only in the sense of understanding it to be something that is social and has no connection to a potential policy, as we talked about political determinants, a potential structure in terms of organizational planning and design, and in terms of interpersonal determinants, which should be addressed by targeting individuals and not cowering under the idea of systemic racism and that it's just something that exists. So lastly, I think that as the CEO of a practice that has decided that care as usual should not be the way that we can navigate this, one of the bright spots is seeing how we recognize that health doesn't begin in clinics, it begins in communities. The work that we do, we integrate actual physical health services into community-based organizations just for that reason. And we almost recognize that these are exacerbated. All of these determinants I talked about are exacerbated by an undercurrent of racism. I want to allude to the words of Dr. Kamara Jones, the former president of the American Public Health Association, particularly because she is a master of allegory. And when talking about racism, a lot of times allegory we found to be extremely helpful. So many of you may be familiar with a moving walkway in an airport. Many of you probably, as myself, enjoy doing the moving walkway instead of walking next to it. Kamara Jones talks about that moving walkway as how racism manifests itself, how we can stand on it and do nothing and continue to exacerbate and propagate and continue to move it ahead. And we talk about this in the way that the only way that we can really start to make inroads is by actively identifying what are the political determinants as legal professionals, as health professionals, as professionals who are adjunct and allied in the fight against equity. What are the ways we can actively turn around and try to walk against, and at times we'll have to run against that moving walkway in the other direction. And as we do it, the other people on the walkway will look at us, they'll laugh at us. And then if they see the way that we're moving and they see what we're doing and that we're relentless, they may actually join us. And so I hope that as we start to think about COVID and vaccination and access to care and treatment, that we think about each of these layers of determinants, the political, and where do you need to intervene in your role, the interpersonal or the structural. And I would like to go back to that 39-year-old Black woman and let you know that she was vaccinated on March 8th. And I know that because she's myself, she is me. And I'd like to let you know that it was not easy at all with the power and privilege that I possess to get that vaccination. And we have a lot of work to do, but we also can do this together outside of not our own silos, but working collaboratively and in an integrated way. I'm really excited. Thank you for the opportunity and excited to hear the other speakers.
Laura, thank you so much. That was a really terrific way to begin today's discussion. I want to turn it over now to Kurlan Flowers to tell us a little about what's going on the ground in the medical legal partnership and in other places where we try and help people one-on-one. Kurlan?
Thank you, Joel. Good afternoon, everyone. And Laura, Dr. Mutuma, I really enjoyed that. So what do we do to help people like that? Hofstra and Northwell partnered to form a medical legal partnership to address health harm and legal needs. We're located in 4 different areas. We're in Great Neck, the 865 Northern Boulevard, the adult medicine. And then we have a pediatric practice at 410 Lakeville Road in New Hyde Park. We're at MSGO, Medicine Specialties of Glen Oaks in Glen Oaks, and an emergency department in New Hyde Park, the Long Island Jewish Medical Center. And we help address these issues by helping patients with income, that would be benefits, SNAP, Social Security, health insurance, or utility issues, housing, evictions, foreclosure, repairs, employment discrimination, education, special education issues, legal status. We help to assist adjust where possible, personal and family law like elder law, maybe even substance abuse or misuse. And you can imagine during COVID, these issues were greatly increased. And we saw an increase of need to all our patients and then our clients. And our clients are usually historically part of the historically vulnerable population. They're no to low income, and they're usually a Black or brown person. And during this time, during COVID, we saw that the Black Americans were dying almost 4 times than white Americans. And yet they were still apprehensive to take a vaccine. And you may wonder why. But there is a high level of mistrust within the healthcare communities with people of color. They've routinely been denied access to care. They receive unequal medical treatment, and they've experienced overt and micro racism while receiving medical care. And people haven't forgotten the Tuskegee syphilis treatment experiment where Black men were used for 40 years by the US Public Health Service and the CDC to conduct a study of the progression of the syphilis disease. So when a somewhat like mysterious illness plagues the world, and it's said that since the Black and brown communities are being affected at higher rates, some vaccine is developed, and now they're supposed to be given first to the communities of color, they're naturally skeptical. What has been done? We know that the PrEP Act, Public Readiness and Emergency Preparedness Act, it provided immunity for any companies to develop a vaccine. It's going to last till 2024. So that means they're not liable for death or side effects of any vaccine. So there's no one really to blame in the court of law if you get sick from these vaccines. You can't sue the FDA because of sovereign immunity. If your employer mandates a vaccine and you become ill, you can't sue your employer. Perhaps you can get workers' compensation. The vaccine court, the National Vaccine Injury Compensation Program, well, the COVID vaccines are not part of the vaccines covered in this court yet because it hasn't been recommended for the routine administration to children or pregnant women by the CDC. So although there can be a legislative change, it's still not covered. There is one program, it's the Countermeasures Injury Program that was developed in 2010. You can recover if there's an illness for this vaccine, but since 2010, when it was developed, only 29 claims were compensated. So it's a program that's a little difficult to navigate, and a death benefit is capped at like $370,000, and you don't get legal fees or pain and suffering. So, people are skeptical because they're saying, well, what happens if I'm injured by this vaccine? The attorneys of the MLP, we informally asked some of our clients to see if we can get the sentiment of the community to see when the vaccine was initially announced. Many were skeptical and they said they wouldn't get the vaccine. And so we wanted to know why. They said they didn't understand how RNA technology worked. The vaccine was developed too quickly. What are the future side effects? Would it cause cancer? If there's a push to get the vaccine to the Black and brown communities, is there something in the vaccine that can cause them harm? Is this an experiment? How often will I have to take it? Is it effective against variants? Some said when there's a change in administration. So we asked these questions when in the previous administration. Some said when there's a change in administration, I'll take it. So we boiled it down. It's a lack of knowledge or of a lack of trust. And so there have been many efforts to combat the lack of trust. The National Medical Association created a panel of Black doctors to vet the vaccine. There were 4,400 and I think it was 3,000 on the Pfizer and Moderna clinical trials of Black people. And it was found that it was safe. And they even tested it against those who have sickle cell trait, autoimmune diseases or lupus. And they found that these vaccines were safe and effective, and they wouldn't have any serious unfavorable effects in the Black community. So the gap began to close. States took on their own campaigns to try to educate everyone about the vaccine. So the gaps did begin to close. 55% of adults now say that they'll take the vaccine. That's up from 34%. That's a 21% increase in 2 months. And those who said they're not going to get it, stays fairly constant. It's 18% now. It was 19% in January. So now that our clients and people are coming around to getting the vaccine, they have no access. And as usually the case, they're going to be the last to receive these resources. National research shows that people of color are being vaccinated at dramatically lower rates. And I'll give you an example. On January 14th, the Armory opened in Washington Heights, and it was set to hoping to target the Latino community who makes up 30% of COVID deaths. However, it was found that the first wave of vaccines went to many white New Yorkers who traveled to the Armory from other parts of the city and state. And actually, I spoke to my mother about this, and she said she has former coworkers that took car service to the Armory and made a day of it and got their vaccine. And those coworkers were white. So a lot of those those in the Latino community, they didn't get the information in time. They didn't get vaccinated. And that scene continues to play out in different parts of New York. Those communities usually have less access to information, transportation limitations, time constraints. If you don't have a computer, you don't have good internet, if you're not comfortable with technology, if you have limited English skills, you're not going to get the vaccine right now. If you don't have a group of people searching for you, if you can't spend hours finding an appointment, you're not going to get one. If you don't have a vehicle to travel from the city to upstate or some place that's super far, you're not going to get one. If you can't take the day off or have backup for family obligations, you're probably not going to get a vaccine. And so our clients are seeing more of the same things during these times, but we hope that through our community collaborations, we can help change the cycle and stop the injustice with almost every part of what's going on during COVID. But we're hopeful that things will change.
Thank you, Kurlan. That was terrific. I just want to put a pin in this for our later discussion, but a really interesting story this morning on NPR looked at the question of how much of the current resistance or skepticism among the African-American community is based on the history of Tuskegee. And what this investigation found is that you don't have to go back decades to find reasons for people of color to be suspicious and skeptical of the healthcare community and of healthcare in general. So while it is an interesting and important touchstone to a historic situation, the wrongs continue, and as you pointed out, with good reason. So hopefully we'll have time later to get some questions. Now, Dr. Renee McLeod. Dr. McLeod?
Thank you. Thank you for the Gitenstein Institute for having me today. I want to speak to you about something that, Amalara and Kurlan have not quite spoken to, but also resonates around vaccine hesitancy and around what we saw with COVID-19. And that's just the idea that COVID-19 forced us to face moral distress. So we've heard this wonderful story of what's going on from Amalara with a patient. And we also heard about the 39-year-old physician and healthcare worker that also was delayed in seeing this vaccine. And I too think that what Joel Roslin said, we don't have to look far to the atrocities in ethics, not only for African Americans in New York State, but to all disenfranchised individuals. I am an ethicist because of what happened in Staten Island in a little place called Willowbrook, where children who were developmentally disabled were exposed to hepatitis C, at that time we called hepatitis A and B, and a young reporter who was a lawyer, Geraldo Rivera, going in there in Eyewitness News. As a 7-year-old, I thought that that was the worst atrocity I would ever see. But as a nurse practitioner that was on the front line of taking care of patients with COVID, and of course, as an ethicist, the moral crisis that we saw just highlights everything that my colleagues have spoken about the structural inequalities, and about the fact that we have a healthcare system that is still unjust, that we live in the greatest country in the Western region, the United States, that has still not adopted healthcare for all. And so I'd like to start as I talk to you a little bit about the moral distress. And as Janet pointed to, having to be someone to consider the unthinkable, how we could possibly ration supplies of life-sustaining treatments such as ventilators. And what it turned out was we didn't have to worry about running of ventilators, but we saw people on the front line having to think about rationing equipment, personal protective equipment for themselves and their communities. So I'm gonna go to a quote from Donald Berwick in the Institute of Healthcare Improvement that says, when the fabric of communities upon which health depends is torn, then moral healers are called to mend it. The year 2020 was supposed to be the year of the nurse. We were supposed to celebrate one of our greats and think about what Florence Nightingale encountered taking care of people during the Crimean War, and how she took care of those people and led to better health practices such that we take for granted now, such as washing our hands. When we talk about moral distress, we talk about healthcare workers knowing the right thing to do, but facing the constraints of not being able to do it, both emotionally, physically, and psychologically. So the Joint Commission really talks about physicians and nurses and other healthcare workers, our frontline healthcare workers, the people who are the data entry, the people that face us as we come into every emergency department, facing moral distress. And what was the single most cause of that moral distress? How if they were to contact COVID, how could they go home? How could they see their children? How could they see their grandparents? And so they also saw death in ways that we have never seen death. And as Kurlan and Omalara have said, we watched disparately as communities of color, as people with chronic illness, as people over the age of 65 were more likely to die from the effects of COVID. Well, how could that be? How could we not have healthcare for all? How could we not offer to the 30 million uninsured proper healthcare? And how could we say to frontline people in these disparate communities that had to take the subways, that we know that the zip code in which we live determined our life? How could we not say to them that they were essential? How could we not say to the Uber drivers, to the Door Dashers, that you are not essential? And yet, we saw this play out time and time again in every demographic data that we look at, that the most disenfranchised in society had the least access to all of the care that would lead to survivability. So as we talk about vaccine hesitancy, as we talk about why these same communities that were so disparate, that have been so affected by structural inequalities, that we did not need COVID to shed a light upon, we've shed a light behind, and what, as Moamara said, not liking social determinants of health. I'm going to call them moral determinants of health. That morally, we know the right thing to do is to provide health equity. Morally, we know that the right thing to do is to provide vaccinations to the communities that are most effective, most disenfranchised, most likely to die. We know that morally, that is the right thing to do. So structurally, politically, economically, why was that not possible? I am privileged that I am a provider in Northwell Health, where we had a CEO that planned and integrated for this event when it was first announced as a pandemic potential in Wuhan, China in December. Why is that? That the structure of everything that we have in healthcare was not prepared in December or January for what was occurring. Now, we can say that this had a lot to do with the federal government. We could say that this had a lot to do with who was in power and our president. But we cannot blame hundreds of years of structural inequality on one political regime or one political president. We have to do better at morally providing healthcare for all, at removing structural inequalities. And so let's get back to what I said about moral distress among nurses, physicians, healthcare workers, social workers, about their rate of vaccination adoption, about their fears and burnout. And let's realize that in order to get a shot into every arm, we are going to need pharmacists and nurses to do that. And what have we done to ease the psychological distress, the depression, the burnout among these healthcare professionals that for more than a year have worked with less resources that they need to do the right thing? Where have we prepared in education and in training and support for these same individuals that are going to be asked to deliver these vaccinations? We've got to do better at opening up areas for this to occur. For me to hear Kurlan talk about the armory being open, for me to have a sister that is 71 years old with chronic health conditions, with heart failure, have attempted for more than 2 months to get on her computer and make an appointment. We've got to do better. We need to help the moral distress of all of our clinicians. We need to get more sites into these disparate communities, communities of color, and we have to provide healthcare for all so that those that are in our community that are immigrant and uninsured are not afraid to get on that line. So thank you for allowing the three of us to share our thoughts on these topics. And we look forward to hearing the questions that you have for us.
Thank you so much, Dr. McLeod, and thank you to all of our speakers. Before we open up for questions from the audience, and I will now ask all of those folks who are online to please, if you have a question, put it in the chat. But I'd like to ask our panelists if any of you have questions or comments for each other. We heard really interesting, unique perspectives from each of you. And I think together they form a really strong picture about what is going on, what the failures have been, and even some ideas for moving forward. But let me just start by asking if any of you have questions for each other. And all of you are unmuted, I believe. Go ahead.
I would like to say, I don't have a question, but something that resonated with what Dr. McLeod talked about, particularly in the sense of preparing healthcare providers and training. I think, so my work at Hofstra has been in the public health program has been teaching around global health. And that is because of a career over a decade of working in countries that are low resourced. And part of that training has included working with residents around how to prepare them for moving into spaces that have very low resources and high burdens of mortality without experiencing huge amounts of depression, anxiety. And a part of that is something called the 4 Fs that I think is really important, and also just important to think about as we think about ways to help providers through moral distress. These 4 Fs include frustration and the idea of knowing something actually usually works, and then under these circumstances it doesn't, and how do you navigate that? Futility, and understanding that despite your best efforts, it won't work in terms of keeping that patient alive, and understanding how to navigate that. Failure, when we're doing things that often a lot of times have been helpful, but just because of the circumstances we're in, it actually manifests in a different way. And then my favorite, floundering, which is the continued identity of not really knowing what this issue or entity is, and learning how to expand and remove your pride and start to identify different resources to navigate it. So I just wanted to bring that up because that came up. It's kind of a core message that we try to do through simulation and through other work with healthcare providers around those four topics.
I think that's so important about all of the work we do. And I think that final 4th F, that floundering, is what we're really hoping that, when this horrible tragedy is over, that there will be lessons for us to learn, and how to support each other, and how to mobilize resources between them that have and them that don't have. So I'm always really grateful that this Hofstra Northwell partnership, we have each other. And then I think about the stories that we hear out of Health and Hospitals or Elmhurst Hospital, that were city hospitals that didn't have those resources.
Other comments, questions from the panel? Then
So,
I am.
if you don't mind, this is Janet. I know
Yes.
I'm sort of marginal to the panel, but I think it's really important that everybody understand, and our speakers do, but everybody may not, that in countries like ours with phenomenally steep socioeconomic slopes, people at the top get sick more often and die more often than in comparable countries with shallower socioeconomic slopes. And, that's a really powerful fact that should lead every single one of us to commit ourselves to the building of communities and the creation of a universal system of healthcare, so that all of us will be healthier.
Such an important point. And I think it really addresses the larger context in which a discussion like this takes place. I'd like to turn to some of the questions and comments that we have received. So it's not a question, it's a comment, but I'm going to turn it into a question. There's a comment thanking Dr. McLeod for your comments, and it ends with this statement. Collectively, we all have the power to change the system step by step. I'd like to turn it into a question and ask each of you 2 questions. Do you agree that we have the power to change a flawed system that each of you has described from your own perspective? And if we do, what are some of the concrete steps that we as professionals, as educators, as consumers, as citizens can take to begin to make the changes that have been uncovered by the COVID virus and also needed no help to come to the fore. So I'd like to start with Omalara, and I will tell everyone that we only have Omalara until the 1 o'clock hour. The rest of us will stick around for till about 1:15. So Omalara, do you want to take a crack at my challenge?
Yes, I think, so very recently I actually I actually left Northwell to start my own venture, and particularly because of the fact that I am a proponent that a lot of the systems that are built at this point, that as we've worked through them, we have a lot to learn about both how they've been helpful and both the limitations. And I think that what's really important that has struck out in terms of creating a model of integration, what we know is that there are a number of different sectors that are responsible for our best health outcomes. And a lot of times what happens is duplication, replication, and not an idea of integration. And so if I would think about this, my answer is completely yes. My answer is that we all have specific stories, particularly the story of Dr. Susan Moore, who is one of the physicians who had delays in care as a physician, resonates with me so much that we were able to coalesce a group of Black women physicians to actually create a coalition to start to work on a bill around addressing those kinds of issues, particularly in terms of how there's a lack of anti-racism advocacy with the patient advocates in hospitals. And so I think if we all identify what is the personal story that you can resonate with through COVID, that keeps you up at night, that you saw yourself in, and understand what is your potential network around you that is either resonating with that story as well, or potentially has the resources, whether that be through policy, whether that be through actual creation of other services within community, whether that be in having the tough conversation with the leadership and letting them know that why does our institution not look like the people we serve, and holding their feet to the fire, whatever that looks like. Those are really the things that we're going to do, but we have to do those in courage, and we have to do those boldly. They are not going to be safe. However, many of us who are in marginalized backgrounds, and I'm really excited to see my co-panelists and see, a real distinction about making sure that there was diversity in this talk. Many of us have recognized that the spaces that we've sat in, the ways that we've moved to our levels, have been through spaces that have not been safe. So we are definitely used to that. And I think we also just have to think about how do we work together and say that if social work works with law, who works with health, and so forth, that we have a better time of addressing these wicked, and Boston, as they call them, wicked, complex problems.
Thank you. Kurlan or Renee?
So I'm gonna just kind of piggyback off of what Malara said. I think part of the issue is, of course, we have the power to change, and as the commenter said, step by step. But I think it starts with community participatory engagement. And I'm old enough to know that things have changed, but we are far too segregated, and we are far too thinking about how we can look at interest for the North Side versus the South Side versus the East Side versus the West Side. And in order for true change to happen, communities have to listen to each other, work together, and work on common interest. So one of the deep, profounding things that hit at the marrow of my gut is that we're talking about COVID-19, but this pandemic, not only was there a pandemic that was a viral illness, but we have a viral societal illness in this American country that has never been healed. So while this was happening, George Floyd was happening. And so we cannot have these conversations about who we are in terms of health until we fix the psychological illness that is at the heart of all of the problems with our health. And so whether we are talking about our Asian communities that have been seriously affected by bias, or whether we are talking about systemic racism that exists. So for us to really make a change as a community, we have to listen together and we have to be American. Not Black American, not Asian American, not Italian American, not hunky monkey American, American, and come around health for all. Curlan?
Yes, I mean, I agree. I do. As an attorney, let me just go back that Hofstra, we offer a class to our students. It's law and medicine together. And in that class, we discuss with the law students these determinants of health, social determinants of health, as it's called. But when we do a deep dive into it, we realize this is all based on policy. All of these issues are based on the policies that are set in place for certain areas. And so we encourage our students based on the knowledge, you all as law students are gathering a deeper level of knowledge on things of the law and how the law affects others. And I think it takes educating ourselves and those who can make a difference to put the laws in place that make things a little bit more equal, so that we don't end up with a Garden City and a Hempstead right next to each other, and we don't end up with the redlining that still is happening in places like Long Island. And when you do vote, don't just vote for yourself, vote for everyone. And when you consider how did that affect someone else, but educate yourself. Don't do it because someone on the television put a good commercial out. Educate yourself. And that's the power we have to change. That's the power each and every one of us have. Just not being selfish in our ways. If you do hear that there's, something's opening up, tell the neighbors that might need help. Help your neighbors. And it's not just Black and brown, it's maybe an older neighbor that doesn't even know how to turn on the computer or doesn't even have one. If we help each other, if we're not such a selfish society, we would be able to make change. And it is step by step, it's little steps. But don't say, well, it doesn't affect me. I have my vaccine. I live in my high rise, or I live in a nice neighborhood and it's all good. It's not, because it does affect you, and it affects you in different ways. And I think we do have the power to change, but we also have to change ourselves in our thinking and educate ourselves and know how to apply it properly.
Terrific. Thank you all. Curlan, I want to turn to you for a moment. Well, we're about to lose Omalara, so I'm going to hold that question. And no, I have no other pressing questions that have come up, but I do want to, I was struck, Omalara, by your comparison to your experience in Malawi and the rationing of oxygen and the incredulity that in 2020 and now 2021, we would be rationing oxygen at the bedside. And I'll tell a quick story. Both of my parents were hospitalized in December with COVID. My father subsequently passed away from an infection. My mother has returned home and is completely on the mend. But they could not be released from the hospital. They were 88 and 89, because the only place in New York City where they could get oxygen was in the hospital. They couldn't be released into rehab because there was no oxygen to be had. They couldn't be released home because there was no oxygen to be had. Is there a lack of preparation, or where do you see the moral and ethical stumbling blocks that allowed a situation that you encountered a decade ago in Malawi that we now have bumped up against in New York City and throughout the United States?
Yeah, so I didn't give first of all, I just want to, I think so many of us have lost so many people, and I just want to give you that space, because to have that happen, it just it's very important for us to make sure we're processing that too, and making sure that all of us, know that you even releasing that kind of information is a process. And so I want to thank you, because I know that there are people who are listening who are very thankful that okay, he understands that, and I'm not alone. So thank you, Joel, for that. And I'm sorry for that. What I would say, I want to give the backdrop about the fact that what happened in Lesotho, where my first order of business was signing death certificates every day for little children, was in the wake of the HIV crisis, and in the wake of the fact that there were people in power who decided in different countries across sub-Saharan Africa that certain people were less valuable than others. In case in point, children. They can't work. They, if they're not pregnant, so they're not going to be, they're not going to impact the next generation. We don't need antiretrovirals for them if we have low resources. Fast forward to now, my concern has always been about the fact that our representation in positions of power, policy, rationing, resources have not looked like the majority of what America looks like. And in doing that, there's a certain lens that those people have, whether it be subconsciously or consciously, about who needs help and about who is human and who is valuable and who requires resources. And when we look at situations that require a preparation and preventative resources, whether that be making sure that there are certain areas that are not low in oxygen, there are certain areas that have adequate resources of health professionals. When we do that, a lot of times that is not done from the thought of, this area is lacking, this area needs more support, let's figure out how to get more financial support for those areas. It's done from a place of, where are the people who look like me? Are they okay? And if they are, then we're okay. And so I honestly think that health professionals, we know a lot of lawyers do it, but health professionals as well need to move into these spaces of actual representation, of representing the spaces of, politics and other places where these meaningful changes need to happen. And I think that also what we need to do is start to think about the fact that Professor Dolgen brought up, which is this idea, not only does America have almost double from the second amount of spending in healthcare per capita, right, than the next country on the list, and have one of the worst outcomes, but also when we look at these countries, the OECD countries, we see that health outcomes are extremely linked to the percent spending on social and safety net programs. And so what we need to do is start to really think strategically about what are we spending? How are we spending? What do our budgets look like? And unfortunately, we won't get into those spaces unless we're knocking on doors, demanding our representatives speak to us because they work for us, and moving in that direction. So that is what I think is really important. And I think that what we should do is really take the anger from having people that we love who have passed away and saying, how do we take that, not from only in sorrow, but how do we move that into action? And find the people who have experienced that same experience as well. I do have to go. I thank you so much for this opportunity, and please feel free to reach out to me with any additional questions. I'd be happy to share that as well and answer more. Thank you, everyone.
Thank you so much.
Thank you, Omalara.
Thank you.
Terrific. There is a follow-up to this discussion in the chat that I want to read and then throw the question out. Folks can read the chat, but it addresses the question of preparedness and ends with this question: how can we address these issues, that is, of being adequately prepared at the state and federal level? How can we address these issues before pandemics impact our population? Renee, do you want to take that?
Yeah, I think one of the things that we too often forget as Americans is we forget our civic lessons. And I think it's really important because this is Gitenstein and this is a law that we are the government. I think sometimes we forget that as Americans, right? That we have the power to vote, that each and every one of us, if in the things that Omalara talked about, we reconciled, could be the president, could be the vice president, could be the assembly person. So I think in part we forget that. We forget about the power of the vote and the power of getting involved civically in community participatory engagement. So I do want to say that first, and then answer why we were not prepared. Why did we, with our power of a vote, allow ourselves to stockpile military supplies, to stockpile other things, and not consider about the needs of the community? And so one of my dear colleagues is on this, and he often reminds me about how do we become prepared? What is our voice? How did we consider decision-making processes that went into caring for patients in nursing homes, as with what you described, Joel, by sharing something so personal, and thank you for that. Why was there not more beds, more availabilities for the skilled nursing facilities for the elderly? Why was there such a shift away from having ICU beds available? So all of these decisions that had been occurring, as Omalara said, slowly over time, now became a Swiss cheese model where everything fell through the holes that we created and the cracks that we created. So yes, I'd like to see my tax dollars much more put towards healthcare than my tax dollars put toward gun ownership in Suffolk County where I live. And yes, as a result of this, I am now more involved in my community boards, am now looking at how do we raise our voices. So how do we become more prepared? We get more involved.
Yes, that is just right. I think one way to repeat and frame what Dr. McLeod just said is that even as we give more per capita to healthcare than any other country on earth, with dismal consequences to show for it, we have absolutely stopped funding and stopped working to protect the public health system. Public health is for everyone. Healthcare costs largely go to those with resources to start with. And unless the individualism that is misinterpreted increasingly in this country as me against everyone else is replaced with a sense of community, the public health system will not be revived, and we will continue to show statistics in healthcare, child mortality, especially for the children of women of color, for poor people in our community, that are unbearable, quite frankly.
Yes, thank you for that, Janet. You know, what you just said brought me to mind of the, those of us who have studied bioethics are familiar with the four basic principles of bioethics: autonomy, beneficence, justice, and non-maleficence. And what often happens is that autonomy becomes of paramount, unquestioning superiority above the other values. And what you just mentioned, Janet, of individualism over the public health is an example of where someone can come along and say, but it's a free country, therefore
Yeah.
X, Y,
So
Z.
it's so interesting. We see a perversion of individualism and of the very notion of liberty in responses to COVID. When people say, I have the liberty not to wear a mask, what they're actually saying is, I have the liberty to kill other people. I do not believe that that's what liberty was ever intended to mean.
I
True.
can't say that enough, Janet. And I think sometimes, even for those of us that live in the bioethics world, we forget that that view of autonomy that was just espoused is Western. So if we were to think about, Africa, what some of the things that, Amalara talked about, autonomy is autonomy within the community. No child is without a mother. So we also have to remember that culture changes and words are important. This is not a medical decision on an individual level. This is, as Janet said, these are decisions that are made on community levels, on societal levels, and autonomy didn't have a place in that. What did have a place in that is thinking about the greater good. So having sat on a lot of these national committees as we were trying to think, as Janet said, about the unthinkable, it was how are we going to give the greatest resources to the greatest good? And also how we were going to include the most number of voices going out to the churches, going out to the skilled facilities, going out in communities that had no access, bringing in the voice of the collective. And that was really what we were thinking about on these principalism. It does not work when we were talking about public health greater good.
That's exactly right. And actually, this circles back to the question I was originally going to ask Kerlan. You talked about the obstacles that your clients bring to the MLP and what needs to be overcome: lack of knowledge, lack of trust, and lack of access. How can someone express their autonomy, as those in the bioethics and the libertarian community so often espouse, when they lack knowledge and trust and even power to get the things that they feel entitled to? And from your perspective, working with clients, can you give some insight into how we might combat this notion of the individual against the larger collective?
Yes. So one of our goals when I speak to a client, I want to give them the power. So even if I even explain to my students, sometimes there's nothing we can do for them legally, but what you can do for them is give them the knowledge of what their rights are, what the possibilities are for them. So if we give them the knowledge, I think it's giving them so much more power than they know. And I read an article, it says like these vaccines, it's turned into the Hunger Games. And that's crazy. It shouldn't be that way for when people are actually dying. It's not a movie. But what can we do? I'm saying it's really just the knowledge. We should, when I find out like, oh, there's an opening, I'll call some of the clients, say, can you get to Jones Beach? Can you get over here? Do you need transportation? It's certainly helping each other. I saw a question on the side. It says, how can it have been done differently? Or maybe what can we do to fix it? I thought, well, why can't they get mobile vans and get into the community so that people don't have to, from different areas, don't have to try to get to the Armory, or maybe even if they can't get to Jones Beach. we were discussing at one point that CVS and Walgreens but that CVS in Freeport doesn't do it, and so we need to make it more accessible, these vaccines. And I also was reading it, it became on a large scale of COVID. A lot of people started to understand what's going on, but before that it was the H1N1. The numbers are still the same. And before that, it was something else. I was even shocked to see that. I was like, well, I didn't even know H1N1 was affecting people like that. But the numbers were exactly the same as COVID. It just didn't happen on such a large scale. I'm sure the doctors they knew that. But this is continuously happening. So I think that those of us who do have the knowledge, give it to someone else. And if you don't have it, seek it out. Where to find it. If you don't have a computer, you can ask, and don't be afraid to ask. Don't be afraid to get in there and get the knowledge and use it.
I think it's so important what you said, and I think back, I'm of a generation that took the last smallpox vaccine, and I listened to Dr. Anthony Fauci talk about it, and I remember what it was like to be in a public school in first grade and be lined up in the gym to make sure that every child got vaccinated. It used to be every community had a school. And it used to be that nurses and physicians were out in the community doing that. We have lessons from population health and how to mass vaccinate people. What I'm seeing in the chat is, what is the future when we are still doing bills along party lines? And I think that's also a problem here, that we were really along party lines. We saw a very divided vote for the last two elections, almost dead evenly divided. And I think we have to really get at the heart of what is causing a lot of the structural inequalities or social ills that we now have taken into a new millennium. We really have to understand why we are so divided in such a division that we haven't seen since the Civil War in the 1864. We've got to really get at the heart of what we are at this country, what we're willing to pay for, and why we are spending so much money and so much wealth is seen at the top 10%. Some will say the top 1% of this country. The division is really what COVID has illustrated, our elections have illustrated, and the social ills that we've seen around George Floyd and all of the divisions. There's a serious division. And until we get our house from being undivided, we are going to continue to see pandemics of proportions that are not only our physical health, but what's more important, our mental and psychological health.
Well, that's going to have to be the last word. And I think it is an important last word. So thank you, Renee. Thank you, Kurlan.
Thank you so much.
Malara.
So many powerful, crucial points. I can't imagine a better group of panelists. And Joel, thank you so much. The moderator role is always crucial, even though that's not always noted, but thank you.
Thank you, Janet. There's a couple of other people. I want to thank Judy Black for hosting today's event and for all your help in promoting and in supporting Gitenstein in our programs, as well
and
as
Andrew Berman.
Andrew Berman, and also Dean Gail Prudenti,
Of course.
who is one of our biggest allies at the Gitenstein Institute. Today's discussion, I think, really embodies the broad scope when we talk about bioethics or public health or public policy here at the law school and throughout the university. This is the kind of integrated discussion that we hope to foster, and that we will have many more opportunities to do that in the future. So with that, I draw today's presentation to a close. Again, thanks to all our panelists, and thank thanks to you who participated. And so please be on the lookout for more events coming from Gitenstein. Everybody have a super day, and we look forward to seeing you again.
Thank you.
Hi, thank you.
Bye-bye, everybody.